Thanks very much, Jim. I really appreciate that, and thanks to everybody for inviting me. It's certainly a pleasure to be here in Seattle to one of our few sister full departments here, and it's been great meeting with everybody over the course of the last day. What I thought I would talk a little bit about is sort of next generation laboratorian, next generation pathologists, the kinds of things that we are going to be doing, and then mostly concentrate on some of the issues we have in terms of educating people, both at the medical school level and at the residency level as well, and kind of go through some of the issues that we have out there, go through some of the data that we have in terms of how well we're doing or not doing, and maybe talk a little bit about some of the things that bother me the most and that I think we should be looking at to do in a slightly different fashion. So it's pretty hard to have a conflict of interest with respect to educational things, and indeed I don't have any conflict of interest, so I've now done my CME thing here for the day. So when we look at this, we're going to try to discuss a couple things, and one is sort of how the job of the pathologist, in particular the laboratory medicine pathologist, is changing. Where we are in terms of educating all of our young colleagues to meet all of these challenges. And also a little bit about how good we're doing or not doing with respect to educating other clinicians as consumers of the massive amount of data that we produce in the clinical laboratories. And I think the theme here, in a sense, is sort of laboratory medicine and pathology in a time of disruptive innovation. And you know, our colleagues in the business world have recognized for many years that a lot of what drives their respective industries is all innovation that comes along often suddenly, often unexpectedly, and that one then spends one's time sort of catching up with and trying to figure out how to incorporate it into a business model, or in our case, into a clinical model. And they always think of this as sort of divided up into the processes that you use, what you offer to your consumer, and consumers for us, of course, are both patients and other physicians and clinicians, how you deliver that, and of course, how you finance it, and that's what we'll talk the least about today. And if you think about all of the things that have happened in the last 5 to 10 years at most, in terms of the kinds of things we do, I think it's a pretty obvious list. We certainly are engaged in digital imaging we weren't engaged in before, and I'll talk very briefly about that. Things like big data, next-gen sequencing, the microbiome for us has been a big initiative that we have in the clinical laboratories at Yale to try to bring on board proteomic areas, offering whole exome, whole genome genomics, cellular therapy, which I'm going to say a few words about, that again I kind of believe is in our realm and not in other realms, and I think we do a good job at that where we are engaged in that. Things like in vivo microscopy, and then delivering this to people through things like integrated personalized pathology consultation, telepathology, what people like to call primary care pathology, and the bottom line of all this is that the way we are paying for healthcare is clearly going to have a major impact on us, and we'll come back to that in just a few minutes as well. So let me just go through a couple of these things quickly, and then we'll kind of turn to where we are from the educational and the practical care delivery portion of things. So we're all familiar with the fact that genomics has become a big part of our lives. That ranges from somatic cell genomics, for example, at Yale, and I know you guys are engaged in this here as well. We have a relatively new, several years now, molecular tumor profiling laboratory. I think because it sounded good to call it Formula 409, we have 409 genes that we test as sort of an integral part of all the cancer diagnostics that's being done at the institution. A variety of those are, they're mostly in signal transduction pathways, as you can imagine. A variety of those are not, we don't bill for, because they're in pathways that don't have actionable consequences to them, and then a variety that we do bill for. Whole exome, whole genome sequencing potentially brings us into the era of what people like to call preventive care pathology or primary care pathology. I'm not sure whether we're going to be doing that, the geneticists are going to be doing that, the internists are going to be doing that, or whether we really are going to be taking everybody in the world and doing whole exome analysis on them. If we are, I suspect what's going to happen is that we'll start doing it as soon as you're born instead of all the postnatal screening that we do right now, often in the state laboratories. In our environment, we do about half of it. The state lab does about half of it. And that certainly will change how we're looking at things. We're actually been very interested in microbiome. We have the belief that this is going to become a clinical test over the course of the next 3-4 years. I don't know if I'm right about that. I may be 100% wrong. We've kind of set up a microbiome analysis by NextGen in our laboratories. We've set it up at the moment as sort of a research core, and that's how we pay for it. But our prejudice is that we may be doing clinical testing on that within the next couple of years. We'll see who's right. Having said all of that, and having said that places like ours are doing this, it's interesting that if you look at data that Rick Haspel had collected, now it's about 3 or 4 years ago, and just kind of surveying residencies in pathology and laboratory medicine, it turned out that almost 70% of the residencies had no real formal genetics teaching. And I think this is an issue out there. And again, I think there are some programs that obviously are right on top of this, but others that are not. And I think something that we need to deal with as a discipline. Digital pathology is an interesting area, and I'm going to show you a little bit of, I'm just going to show you a cute movie in a minute from one of our faculty. A lot of digital pathology right now we're kind of dealing with in a very pragmatic way. We're using it for telepathology, for distance consultation, kind of the kinds of things we're doing right here, but with slides in front of people to look at, whether it's in heme path or surgical path or where have you. There's a variety of barriers to it, but the most exciting part of digital pathology to me is whether or not we're going to end up with new improved methods for doing various diagnostics, and that's really where I think the money is in the digital pathology world. So I just thought I would show you because I think it's a cute application, and I suspect there are people here doing this kind of thing as well. So one of our faculty members, Rick Torres, who grew up as a bioengineer and then went the clinical pathology and hematopathology route, has been very interested in trying to come up with rapid mechanisms and methodologies to do high-resolution, non-destructive 3D histology, with the idea that if you haven't fixed a tissue, there's a lot of molecular assays, proteomic assays, and what have you, that you can do to it that is easier to do and better to do on non-fixed tissues, at least initially, and can you come up with a way of doing this in an efficient fashion that would actually work in a more standard surgical pathology operation. So what they do is he and his colleagues take, and that's a breast biopsy there, and they use this optical clearing methodology, and I'm not going to talk about the details of it, rather than fixation, which again is non-destructive. Then they basically do their sectioning by a computer and microscopy. They have a homegrown multiphoton microscope, and it leaves the tissue intact so that you can do any number of ancillary studies that you want on it. The thing that's kind of cute, this is a breast biopsy that this is not, it may look like H&E, but it's fooling you because it's just the computer's version of H&E. And what they do is, this is literally that tissue, which took them approximately 15 minutes to prepare and put into the microscope. And this is walking through it from one end, if you will, of the z-axis to the other end. So from one end of the tissue to the other. So you really can get a sense of where, in this case, the adenocarcinoma cells are relative to the normal tissue. You can follow things through the biopsy. You don't have to look at multiple slices. The fact that they can color it like this actually makes even our, dare I say, oldest surgical pathologists semi-okay with it. They still don't like the idea that it's a computer. But they can deal with it because it looks like what we were all taught to look at. And so it really is, it's very quick. It gives you the entire biopsy. You can look at all the different parts of it. You can do a variety of additional ancillary studies on it in a non-destructive fashion. This is my favorite, being in the hematopathology world. See if I can get this to run here. And this is a bone marrow biopsy, and again, using the same kind of technology. What's kind of cute about it is in 3D, if I can find the cursor here, which I may not be able to, in 3D, you can actually get a good sense of what the megakaryocytes look like if you're looking for dysplastic megakaryocytes. You can get a good sense of where the collagen fibrosis is. They do these other fancy analyses with second harmonics to get there. And you can actually follow blood vessels through the bone marrow as well, which we have some projects on looking at now. And for whatever reason, I'm having a hard time finding it, but trust me that would look very similar to the breast biopsy, except walking your way through the bone marrow biopsy that we have there. Other areas that are coming along, and this is more on the anatomic pathology side of things, but again, I think areas that we're not necessarily currently training our trainees for, that may be coming along significantly in the future. In vivo microscopy, I actually don't know what things are like here. We're probably behind the curve in New Haven in terms of in vivo microscopy. But if you look, when it was surveyed about 2 years ago, there was something more than 50 academic medical centers that were using in vivo microscopy. Essentially what this is you stick some kind of miniaturized version of what I was just showing you in essence with a multiphoton microscope type of technology on the end of an endoscope. Some people do this in coronary vessels actually by sticking it on the end of the wonderful little catheters that the cardiologist can stick through your coronary vessels. Classically, or more frequently, this is done with standard GI endoscopy. And again, I won't show you all the pictures just in the interest of time, but you can basically get images immediately as you're doing the endoscopy that look not nearly as good as what I was showing you a minute ago, but give you a reasonable sense of whether or not something might be cancerous, precancerous, normal tissue, and so forth. And the real question is, how do pathologists actually go ahead and interact with this? Because are we going to have telepathology where we're sitting while somebody is doing the endoscopy? Are we going to be standing there and do the endoscopy ourselves? I don't think that's going to happen. So it'll be interesting to see what happens. The CAP has this on their list of things that for the transformation of pathology in the future. And when they surveyed pathologists, again, just a couple years ago, there were only about a third of pathologists that were even familiar with the fact that this existed, and fewer than 2% that actually had any direct experience with it. So I think this is an evolving area that we're going to have to keep our eyes on over the course of the next couple of years. Similar to all that, and you're all well familiar with this, we're looking at major changes and major improvements in big data, informatics, obviously essential in the area of the genomics that we're looking at. We have great interest in this from the proteomic point of view as well, and even analyzing the massive quantities of data that we produce on patients every day that we tend not to do we tend to look at not in a multi-parameter fashion, right? We kind of look at their creatinine and then in an isolated way, and then we kind of look at what their crit is, and we never really kind of put that all together. So I think all of this is moving along, and all of this is going to have to be both handled by our information systems, but predominantly by our human brains, and that's where some of the difficulty, I think, is going to be. One of the things that I'm actually very interested in, I'll take a minute or two and talk about this before I get into some of the data on where we are educationally, is what I always like to call therapeutic pathology, or you can call it therapeutic laboratory medicine, but it's all really the same thing. I think a lot of us have gotten used to get-togethers of pathologists, pathology chairs, all these wonderful folks, sometimes in nice places like Tahiti, sometimes in less exciting places like that, and talk about the future of pathology and what pathology is really. And one of the things that people tend to say is pathology is the diagnostic specialty, that what puts us all together and what tries to put AP and CP together and all of this kind of stuff is that we're all about diagnostics, and we're just better about diagnostics than any of the other subspecialties. And I would argue that that limits us too much, and that isn't really what our fundamental similarity is for all the different kinds of things we do. I think what gets us all together is that we're the specialty that encompasses anything that can be done in a clinical laboratory on individual patients. And to me, that includes potential therapeutic things as well as diagnostic activities as well. So manipulating stem cells, doing cellular therapy for infectious diseases, for immunological diseases, all the other aspects of regenerative medicine are really something that I see at least as falling into our bailiwick, and something that we have unique expertise in that other specialties don't. It's kind of an extension, if you will, of transfusion medicine and apheresis services that most of us have in our departments, and I think we're the people that really understand the technologies and can utilize the technologies well. We've kind of worked on this a bit at Yale. We have our Department of Laboratory Medicine runs our Advanced Cell Therapy Laboratory at Yale, which is at the moment, and we actually do some things that are just standard clinical care, if you will, having to do with the stem cell transplantation program. But we're also involved in a whole host of clinical trials which I suspect are going to go somewhere, and I have a love for this from literally 30 years ago, because I did some work in this area way back when. So we have, for example, some trials using Treg T cells for type 1 diabetes to try to ameliorate it or prevent the progression of type 1 diabetes. Some trials creating and separating out particular subsets of T cells for the aficionados, CD45RA T cells, for example, to try to prevent graft versus host disease, but at the same time preserve immune reconstitution in patients who are undergoing allogeneic stem cell transplants. And even some programs dealing with wound healing and mesenchymal stem cells, and one of the things that's kind of big around our way is growing blood vessels on scaffolds. The bioengineers are incredibly clever about making these scaffolds that cells happily grow on, and so we get the cells, we manipulate the cells, we do that kind of things. They plate them onto the scaffolds, and then the surgeons try to put them in individuals, and it's particularly valuable for pediatric patients, where if you put a vascular graft into a pediatric patient, you have to keep redoing it every so many years because they're growing all the time. It's much better to put in something which is basically a scaffold, autologous-based blood vessel, which then the scaffold eventually dissolves, and then the blood vessel grows like a normal blood vessel with the child. And that's actually fairly successful so far, which is nice to see. So when I present our department, and I think this is true of any laboratory medicine department, when I present to the other chairs and to the dean and whatnot, I always think of us again as having two arms, a diagnostic arm and a therapeutic arm. And I think as we're training the next generation of laboratorians, it's one of the things we should think about. One other area that I think has potential out there, and we're all doing to one extent or another, is, in a sense, I hate to say taking over benign hematology, but there's an issue out there in the general, in my view, in the general world of benign hematology. You know, for many years, internal medicine would produce hematologists and would produce oncologists. And then, in large part driven by financial considerations, more and more programs, and now almost all programs, except for a handful, produce hematologists, oncologists, and what tends to happen is that 95% of what you do is oncology, and 5% or less of what you do is hematology. And it's left this real gap in terms of benign hematology practitioners out there. One of the things that's kind of interesting, and this is true, I know in our place, it's true down at Baylor, it's true at UAB and a number of other places, what's sort of gradually happened, and I think it's not a bad thing, is that our transfusion folks have become a bit of therapeutic physicians as well, particularly when it comes to managing coagulation. I mean, if you think about managing coag, right, I mean, the 90% of it is kind of a laboratory testing for it, which is complex and not easy to do and to interpret properly, and many of us have interpretive services that we try to help everybody in terms of interpreting these impossible tests, coag tests that we do. And then the people who are treating many of the coagulation things tend to be our transfusion folks because it's factor-based and those kinds of things, again, depending on what the patient has and all that. So Chris Torme in our department has actually gone and proposed developing a curriculum and a distinct track of training in this, and we did have two transfusion medicine fellowship slots. We've now added a third, and the goal of the third one is to produce people who will do sort of coagulation and transfusion at the same time, and it's an experiment. We'll see where it goes. If you actually look at people with and their various board certifications who are certified in transfusion medicine, it turns out about 15% of them already, at least by board certification, that can be, you can take what you want for board certification, are already kind of co-certified in enough areas that it would make sense that they would be able to do this. Like everything that always seems like a great brand new idea, it turns out it's not a brand new idea. If you look at, and many of you know that in Europe, the whole practice of anatomic pathology and laboratory medicine is a very different model in terms of who does it, how they do it, how they mix and match it. Turns out in the United Kingdom, the benign hematologists who generally do transfusion plus coagulation and to some extent hemoglobinopathies, which again are mostly diagnostic issues in patients, is actually certified through the Royal College of Pathologists. And so they sort of already have this model out there. So in a sense, we're just sort of looking to see whether or not this kind of model would actually work in the United States. So it's an experiment. Stay tuned. We'll see if it goes anywhere. We're also encouraged to do this by the fact that there certainly is data out there that consulting a clinical pathologist in the management of a patient with a hemostatic difficulty is both better for the patient and cheaper for the healthcare system. This is data actually from Marissa Mark at UAB that she collected now about 10 years ago, where they, about 10 years ago, they went over to a system where if you wanted to give a coagulation factor, you had to get a formal CP consultation. And it's done generally by the transfusion folks, although a few of their hematopathologists actually kind of join in on this, but it's predominantly the transfusion folks. And you had to get a consultation. They had to go through this with you. They had to decide what to do. And she published some nice data, which has been seen by others as subsequently as well, on cost reduction and better patient care associated with it. And I think it's an interesting model that we're going to see out there. All right, so let's talk about one other area that I think relates to all this, and then we'll relate to training, and I really will get to the education part of this in a minute. So what the future of laboratory medicine should be and is something that isn't just being considered by people in laboratory medicine. The CDC, starting in around 2008 or so now this is an ongoing effort for about 5 years with the CDC, actually decided they needed to get a national status report on laboratory medicine. And they did the typical thing that you do in Washington, which is you get a beltway consultant in and probably pay them more than our combined salaries for the year to do this, something that we probably could have told them. But nevertheless, over the course of 4 years, they did a national status report on lab medicine, came up with an executive summary of about 2 pages or 2.5 pages or something like that. And in that executive summary, they had a couple things which I think are of particular interest to us in this context, and probably not surprising to us. One conclusion was that expanded laboratory medicine consultation services to clinicians would contribute to improved patient care as well as patient outcomes. And they were even smart enough to realize what, again, I think we could have told them, that the primary barriers to more and more of these interpretive consultations happening in clinical pathology is lack of reimbursement for the consultations. And although we all love to volunteer our time and do these great things, in the end, we kind of have to put shoes on our children and pay for this. And so that's an issue. And there's really some shortage of subspecialty expertise, which basically I think is reflecting, and we'll come back to this, the level of our education on the laboratory medicine side of APCP in terms of resident training and what we're doing in terms of medical school training even before that. This is something we've gotten very interested in. We're looking at other types of consultation models where we are in Connecticut. One of the things not mentioned by this report, but that we've realized is an issue, is we were actually trying to look at whether or not if we, with the electronic medical record, it's theoretically easier for us as laboratory medicine people to consult at hospitals that are distant from us if we had access to the electronic medical record. We often don't have to see the patient. What we need to do is see all the data on the patient. And one of the struggles that we have as we were looking at this, and I don't know that we'll be able to overcome it, we were thinking of a little pilot and then realized all the issues we had, is that you basically have to be credentialed in every hospital where you do this, and you have to be appropriately licensed. So in a place like this, you guys are kind of surrounded by the entire state of Washington, but we are surrounded by other states, and we're really small. So we were looking at going into Rhode Island, Western Massachusetts, and New York, and that would mean all of our folks would have to be licensed in all 4 of those states, and that becomes, again, just sort of a strategic problem to getting this done. In that same report, and this will switch us over now to talking a little more about medical education, the CDC also recognized that medical education on laboratory testing is inadequate. And as they phrased it, despite the integral role of laboratory testing in the practice of medicine, formal teaching of laboratory medicine is a relatively neglected component of the medical school curriculum. Without sufficient knowledge of lab tests, healthcare providers are more prone to inappropriate ordering, mistakes in interpreting test results. This can lead to poor case management, increased cost per patient, and adverse outcomes. And this kind of got us into trying to figure out where we were with respect to education, not just of clinical pathologists, but educations of all the non-pathologist clinicians out there as consumers of the information that we provide on the laboratory medicine side and the information that we provide on the surgical pathology side of things. There's a lot of data out there to say that people that non-pathologist physicians have a tremendous problem interpreting the results of lab tests. And I just went back again to one of the earlier papers on this, which got me partly interested in all this. And this was a study that was done where they took a group of medical students and residents. The residents were all non-lab medicine, non-pathology residents. And they gave them an article to read about a diagnostic test. It happened to be BNP in the diagnosis of congestive heart failure that it was in the New England Journal. And then what they did was they asked them a bunch of questions about it, and then they gave them a simulated patient example that would be based on having read the article intelligently. And when you ask them all those kind of wonderful things, I mean, we're all good test takers, right? Docs all are, because somehow you passed a bunch of tests to get your MD degree. When I asked them all those kinds of things like, oh, could you figure out the sensitivity and specificity and the type of study that this was and where there might be referral bias to the way the study was written, they did pretty well. They got anywhere from 93% right in the medical students to 64% right, depending on the area. When instead they put this all in a clinical setting, they actually gave them a patient example and said, okay, so now you read this article, what would you do with this patient? Fully 3% of the medical students got it right, and fully 0% of the residents got it right. And I think there's been a number of studies subsequently that have really shown the same kind of thing, and I think is reflecting where we are in terms of teaching about the laboratory. So part of what I'm going to show you now in terms of data was collected in concert with a group that the CDC put together, which is called CLIC, because you have to have an acronym if it's a government-sponsored thing. It's a horrible acronym if you learn clinical, it's horrible. And this is a group that actually is co-chaired by Mike Laposada from our world in Lab Med, and by a fellow by the name of John Hickner, who's the chair of family medicine at UI Chicago. And one of the goals of this, and there are several, was to identify educational gaps that maybe could be fixed and what have you. So there are a number of studies that were done. This is just getting back to the issue of, can you interpret a test if you're a non-pathologist clinician, and can you order a test? And this is something that John did with the group and just published a couple months ago, and surveyed about 1,800 primary care physicians, and just didn't test whether or not they really knew what they were doing, just asked, do you think you know what you're doing? And when they did even that simple threshold, 15%, the physicians reported that on average, 15% of their patient encounters, they were uncertain about what test to order. And if you think about the fact that most of the patient encounters are just repeat patients, that's an even higher percentage of new patients, and it's a pretty impressive number. And similarly, they reported an 8 to 10% uncertainty once they'd gotten this result that they'd ordered of what to do with the result that they had ordered. It's kind of sad that if you do this, and the CDC did this as well, I guess 2 years ago, get together some MD focus groups and try to ask, well, how are you dealing with this problem? And this is kind of a sad commentary, hopefully not on anybody in this room or at the other end of the television camera here, but certainly out there in general. Comments that one gets are things like, well, you talk to a radiologist, even a pharmacist in the hospital, you're talking to a colleague. You talk to a lab, it's a black box. I don't think about calling the clinical pathologist. They haven't made themselves available to me. I don't even know who they are. Then there's problems like getting through the maze on the telephone in all of this. And once in a while, you would get somebody who knew who one of the clinical pathologists were, and then would make a wonderful comment like, well, if it's an interpretation, discrepancy, issue of all these kinds of things, I just call so-and-so, who's in charge of the lab, knows everything. And that's how I get my information. So we decided that what we would do is we would just kind of do a survey of lab med education in medical schools and see where we were. So, and this will hopefully be coming out in publication in the next 2 months or so. So we surveyed all of the accredited US medical schools. We actually got a 75% response rate, which I thought was amazingly good. What we found was we asked, do you have any coursework in laboratory medicine in your teaching of the medical students? And 85% said that they did. There was a previous study done in 1992 that had asked similar questions, at least these questions, and it's gone up since then. It was about 69% in 1992. How many of those had required coursework? Well, that was about 78% of all of the medical schools. And not surprisingly, the vast majority were taught in these integrated curricula that we all use these days. The total amount of instruction was not all that impressive compared to many things we teach in medical school. It averaged out to a median, or it had a median of 12.5 hours, about 8 hours of lectures, 4.5 hours of small group problem-based learning, wide range. One institution that was doing 104 to 128 hours of instruction, and some institutions that were doing 0. What I worried about most, and I think this is a theme here, was we asked, do you have your required instruction within the context of direct clinical practice? Do you do it in, say, the 3rd or 4th years in other clerkships or in those kinds of things, as opposed to you put it in with the same day they learn the Krebs cycle, you mentioned something about lab tests, and then they go on to take a look at what a desmosome is. And only 11% had instruction in the context of patients, basically. And I think that's part of the problem that we have. We asked about lab med elective opportunities. About 73% of the schools said they had a combined pathology and laboratory medicine elective, and almost 60% said they had a dedicated laboratory medicine elective. We'll come back to that in just a minute, because that's what the schools told us, 60% dedicated laboratory medicine elective. So if they really wanted to learn it, we had something we were offering them. Then if you get to how seriously are people taking this and what are they doing about it, turned out that fewer than half had any kind of formal review of the laboratory medicine curriculum. They had formal review of nephrology, cardiology, many other things, but not of laboratory medicine. Did they assess their competency in dealing with these laboratory testing and interpretation issues? That was rare, 8% of the schools. Half were aware of published curriculum. That was particularly sad to me because I had led a group from Eclipse in putting together curricular and all of this. But I guess it's either half full or half empty. It depends on how you want to look at it. And then one thing which I think is of some interest is at least half of them said that if we had some kind of standardized exam or some kind of methodology that we could help them out with in doing these things, they would take advantage of it. If you ask what were the barriers to laboratory medicine education, and I apologize, it's hard to read the graph at the top, but the summary is on the bottom there. They basically came up with 5 things that were considered to be a big issue. The first 2 are lack of sufficient time in the preclinical curriculum and or in the clinical curriculum. Everybody complains about not having enough time. So that's kind of the de rigueur complaint about what you can and cannot do. Probably more telling, and I think we would probably all agree with this, was lack of knowledge of best practices by interns and residents who then go on and teach the students, and then they believe the interns and residents and whatever we've taught them kind of gets lost in the shuffle. Same thing, lack of knowledge of best practices by attending physicians. And the saddest part was lack of student interest was 63% of the schools said we had issues with student interest. And I suspect that relates to the other 2 things, which is their interns and residents don't care about it, and so they don't either. We did decide, we did that, and then we decided, gee, maybe we should do a reality check on this. We'll survey individuals taking the RISE exam and ask them about their medical school experience. So we did this with ASCP about a year ago or so, and actually got about 312 respondents. And when we said, in preparing your colleagues to become consumers of laboratory and pathology info, did your medical school devote adequate time to the following, and gave them a list of things. And not surprisingly, principles of diagnostic testing, transfusion medicine, how to read a surgical pathology report and make sense out of it. All these things were considered by the residents that their medical school had not done a good job in teaching them. So I think if we talk about kind of lab medical school education for non-pathologists, the bottom line is if we expect physicians to do the right lab test at the right time every time, we really have to start teaching them better, because I don't think they're getting it. And I think we need a national assessment of really where we are. I think the only thing that would also help that out would be to build up on the consultation stuff, but that has major problems out there, as we've talked about. And we may be able to build a little bit of this into real-time diagnostic informatics, but we'll have to see. So let me just say a few words then about whether medical school teaching is adequate for everybody who chooses a career in laboratory medicine and or in pathology. And again, this is Cap's idea that we're going to do all these wonderful things as pathologists in the future and add all this to whatever it is we're doing now, which clearly we have so much extra time based on what we're doing now. So we asked the residents what areas of pathology were included in their core or elective medical school courses. And again, they had real problems with having enough genomics, enough transfusion medicine, and all these other kinds of things in their medical school teaching. This I thought was also kind of interesting issue. We asked them, did your school offer rotations in surgical pathology, autopsy pathology, and laboratory medicine? And 70% said they had an elective in surgical pathology. Okay? And even though the schools said that 60% of them had an elective in laboratory medicine, all the residents could remember was about 27% of the schools having it. So I'm sure they just had a memory loss and that the schools were absolutely accurate with respect to what they told us. It's interesting, too, of what students do during, say, a surgical pathology rotation versus a lab medicine rotation in most places. So about 3/4 or so, a little more, of the pathology residents had done a rotation in surgical pathology before they became a resident. If you asked what they were allowed to do and or required to do, they were generally required and or allowed to gross some simple specimens, to sign out all or part of a case, to collect the histories and do those kinds of very active kinds of things. To me, very similar to what you would do in internal medicine rotations or surgery rotations. If you ask about lab med rotations, there obviously weren't as many that had the opportunity. Only about a third had taken such a rotation. And if you asked, were you allowed or required to do sign-outs, transfusion reaction workups, learn about apheresis, do lab rounds, do consults of various types, it was a very small number that had included that inside their medical student teaching. So overall, about 50% of them at best thought that they had a reasonable grasp of knowledge and procedural competencies to start their residency in pathology, and the rest thought there was a real problem. So I think medical school training is really, really good at producing great internists. I think it produces good pediatricians and surgeons. I think on day one of all those residencies, they're in good shape to do what you have to do as a resident. It's not at all clear to me that on day one, our residents have been as well prepared to do laboratory medicine and pathology. And I really wonder about whether we should be doing significant things with respect to the medical school curriculum to make that better for them and to make it better for the patients who they're going to be involved with. Well, let's turn our attention for just a minute from medical school teaching to residency teaching. And we've done a variety of things on this over the years. I'll just show you some of the, it's going to give you some summary kind of stuff. So again, if you just go to the residents and ask whether, now this is talking about residency, not medical school. So did their training program, or not actually we didn't ask whether your training program did this well, but if you thought about all training programs, do you think there's effective training in the following? And the topics that came below the 50% range included lots of the laboratory medicine things. Molecular, microbiology, coagulation, immunology, chemistry, management, informatics. The only lab medicine subspecialties that did a little better was blood bank and heme path in all of this. So their feeling was that residencies weren't doing the best job. Now that's their subjective opinion of it. The question is, do we have any way to kind of measure outcomes that would tell us whether we're being effective or not? And I don't know a really good way to be able to do that. There's been at least 2 studies that I'm aware of that have tried to look at this with surrogates, if you will. One, and I apologize that it's hard to read the slide from back there, but I'll tell you what it says. One of the ways to try to look at this is to measure the incremental improvement in test scores for the in-service exam over the years of residency in particular areas, okay? And it's measuring the same cohort of individuals over time. What you find is that if you look at how they improve in, say, answering surgical pathology questions, it's a very dramatic upward curve, and I won't show you all the details, but it's a very solid upward curve. So over time, they do better and better at surgical pathology rotations. They do better and better in heme path. They do better and better in cytopath. What they don't do better and better in, and tend to plateau, so they're not doing much better in year 3 or 4 compared to what they're doing in year 1, is microbiology, clinical chemistry, laboratory administration, and forensics on the AP side of things. Now that could just be because the RISE exam is awful and therefore really isn't testing them, or it could be that we're not doing the best job at teaching them. The one other area that has been looked at is to try to figure out when the residents go to their first job. What do they feel most comfortable in, but more importantly, what do their supervisors, the senior members of a community practice, for example, or if they've gone to an academic center, the chairs and chiefs of the services, what do they think the residents are coming in prepared to do well? And they do pretty good in most areas. Again, the ones that really fall down are clinical chemistry, microbiology, and laboratory administration. So I think we're developing a theme, right, with this, and I think it's a realistic theme, and I think it's something that we're seeing, and that is that we're just not globally, and that probably, to a little bit this is coals to Newcastle, because I think here and I hope in New Haven we're a little bit different than this, although I don't have great objective data, I guess, that I've collected on this. But as a whole, we're not doing a good job in our discipline. I would just say a few words, because near and dear to my heart is producing physician scientists or pathologist scientists, a little bit about that as well. And this is not to be discouraging, but it bothers me a little bit. And so I'll tell you why it bothers me a little bit. So it turns out that about a quarter of graduating pathology residents go to jobs in academia. But the vast majority of those jobs are purely clinical jobs. But it is a significant portion that are going into academia. If you look at medical sciences training programs, MSTP programs, MD, PhD programs in our medical schools, traditionally of the folks coming out of those programs, pathology was either the second or third favorite subspecialty to go into. Medicine and pediatrics often would lead it in the old days. That was true up until just about 3 to 4 years ago. And Skip Brass has collected some more information on this. And now, if you look, pathology is falling down to number 5 or 6 or even a little bit lower on favored disciplines to go into. And things like dermatology, therapeutic radiology, even neurology are beginning to rise higher on the list. And I'm not sure why that is. I think there was a hypothesis that perhaps this has a little bit to do with the fact that as opposed to the American Board of Internal Medicine, the American Board of Pediatrics, Neurology, Anesthesiology, Dermatology, and actually others as well, surgery, all of those other boards have a formally sanctioned program for a physician scientist track. And the American Board of Pathology did not have that. So there was an interest in trying to create such a formal track, even though many of us are training people, obviously, in this area in a limited number, but an important number of medical schools, of training programs. There was an interest in trying to get the American Board of Pathology to do that, to create a physician scientist track. The unfortunate part of it is what the board would agree to was essentially just an add-on year. So you have to do exactly the same training you've always been doing, but you need to do another year of research, which somehow doesn't quite get it all right? I mean, doing 1 year of research isn't going to really get you there, and if you're not going to change what your other training is, then I'm not exactly sure what we've gotten out of all of this. So the hope is that this is only phase 1, and that by phase 2, we can start moving towards the kinds of things. All the other boards have real variations. What they basically all assume is that physician scientists are not going to be generalists. They're going to be specialists. And as long as you're going to be a specialist, you don't have to learn everything there is to know in internal medicine. You need to know a base of information in all of internal medicine, but you don't need to know everything. And if you're going to become a cardiologist or you're going to become a hematologist, and you're going to be a physician scientist, you can shorten down the generalist part of all of this and take the part that you need to be a subspecialist, keep that roughly the same as it's been before. It might shrink a little bit, but usually keep it about the same. And then you take that other time that you've collected and you allow the individuals who want to do a physician scientist track to start doing their research and start working in that area, so they see it as an integrated kind of part of their life in all of this. They also have whole different longitudinal models for how you train people, and that the American Board of Pathology theoretically will allow in the current formulation. That is to say, where you say do nothing but clinical work for the first 18 months or whatever you're going to do, and then you do it as part of what you're doing. So you spend 20% of your time in the clinic, 80% of your time in the research environment, but different variations and individual programs are allowed to pick the variation that that they want to do. So, so where are we in laboratory medicine and pathology training? So I think what at least the board and ACGMA and everybody has kept at the moment is that Pathologist 2.0 has to be all things to all people, and it's going to add all those wonderful things we were talking about in the beginning to what we're already learning, and that'll be just fine, and that will work wonders, and we'll be able to be generalist pathologists forever doing more things than we're doing now. I think medical schools aren't pre-training well for pathology. I think they do worse for laboratory medicine than they do for anatomic pathology, but they're not doing that well. I think residency training in our discipline continues to struggle in a variety of areas, at least nationally. I think, again, at places like this, we do much better, obviously. If you look at what the marketplace is telling us about this approach to training the next generation of laboratory medicine and pathology practitioners, what they're kind of reflecting the reality of the fact that the knowledge base is getting to be ridiculously large to be encompassed within the kinds of programs that we have now. Virtually all residents now do a fellowship. The only exception to that, at least in our place, tends to be the physician-scientist folks. And even some of them, particularly if you're interested in transfusion, will do a fellowship in addition to their CP-only residency training. And about 40%, according to ASCP, do 2 fellowships. So what's that telling us? Well, to me, that's telling us that the marketplace, both the community practice marketplace in particular, but also the academic medical centers, are kind of expecting specialization training. They're kind of trying to tell us that total training for generalists isn't going to work in 3 to 4 years if you're really going to encompass all of AP and CP. I think this is reflected in numbers that are changing with respect to the average size of the community practice of pathology. Average practice size has grown very significantly over the last 10 years. Nowadays, it used to be that the majority of practitioners were in groups of pathologists of less than 5, of 3 or 4 pathologists. Now, 60% are greater than 5 pathologists, and this is actually data from, I think, a couple years ago, 2 years ago probably, and I think it's just increasing. And 40% have more than 11 pathologists, and 17% have more than 17 pathologists in the group. This, although it doesn't quite come out of this data, I believe this also suggests and is reflective of the fact that we're seeing increasing specialization even in the community. And to accomplish that, you need to have a much bigger group so that not everybody is doing hematopathology, and not everybody is doing cytopathology, and not everybody is doing transfusion medicine. And you've got at least one person there who's trying to do most of your CP. Medicine, pediatrics, physician scientists are expected to be subspecialized. The boards recognize that. They modify training appropriately. And even in practice, medicine, surgery, even peds, peds probably the least of those, but nevertheless have moved towards a subspecialist friendly, if you will, training model, and also a subspecialty friendly practical model of how care is actually delivered. So it's my own thought, it's my own feeling that what we're demanding now is to create, kind of super pathologist, in 4 years. Somebody who kind of does all of these things beautifully well, meets all of the challenges that CAP calls transformation of pathology over the future. And I'm not really sure that that's the right way to train people and that it's the right way to practice. And I don't know the answer to how you make a more specialized, friendly paradigm for training. I know that most of our large academic departments, like the one here, obviously do this to a large extent and have done it for a number of years. But I think the community is moving in that direction, and it's never, let's face it, it has never really made sense that if you want to be both an anatomic and a clinical pathologist, you have to do 18 months of anatomic pathology and 18 months of clinical pathology. But if you just want to be a clinical pathologist, then you have to do 36 months of clinical pathology. And then we throw on that a couple random specialty fellowships, although we don't really make difference in terms of how we credential people most of the time for those areas. So we happily credential you in transfusion, whether or not you've taken a transfusion medicine fellowship. I'm not sure any of that really, frankly, makes sense. And if I had my druthers, not that anybody in the American Board or ACGMA would necessarily listen, I think we need to start looking at this seriously and figure out what we really should be doing. And I think there's some people who would like to move us in the other direction to say, get rid of CP, get rid of AP, merge it all together and make these great generalist pathologists. I just think it's a recipe for failure and isn't going to happen. So I'll end with that. There have been, as you can imagine, a remarkable number of people that have been involved in the various educational studies here, because these are all things that go over multiple institutions, and I thank all of them and a large number of people from here who helped out with this as well. So that's what I have to say, and I thank you very much for your attention. Brian.
So you mentioned no specific physician-scientist track in pathology. Isn't AP only, haven't AP only and CP only been de facto physician-scientist tracks?
So it says here, please repeat questions. So I'm going to do that because I'm a good boy. So the question is, aren't AP only and CP only tracks sort of de facto physician-scientist tracks? And I think that's exactly right. I mean, that's what we've used them for over the years, and I think that makes sense to do that, and it's sort of the first tier of the subspecialist model. There's kind of the AP only plus neuropath combination program, which has also existed in the American Board of Pathology on the AP side, as an example of that. And so I do think that a number of us have used it in that fashion for a physician-scientist track. I think the struggle with it is, it isn't entirely clear to me that again, for the same reason we were just talking about, AP, CP versus AP only and CP only, that it's totally the way we would like it to be. So formally, right, if we use CP only as a physician-scientist track, you have to do 30 months, according to the board, of full-time clinical work and not set foot into a research laboratory under any circumstances, and then 6 months of research work. The one thing that the new rules have changed is that they are theoretically friendly to a longitudinal approach, so that you could, over 3 years or 4 years, do things where you are in the lab, but you are also covering a laboratory, doing a senior rotation in there, what have you. And I think that's a bit of so I think a number of programs like this one, and ours in New Haven, have done that de facto over the years. But I think we need to do it in a more rigorous fashion and a more extensive fashion.
Thanks for a wonderful, thought-provoking talk. I'd like to maybe just sort of throw out a little bit of jargon and see what your reaction is. So you mentioned at the beginning how changes in the economics of the system will affect us, and in particular, sort of, the whole idea of that we're now in, where there's going to be payment for an episode of care and not just per procedure. So what about the concept of what we might call Part A pathologists, in other words, the skills involved in sort of managing services within a system, as opposed to the skills of managing individual cases and individual patients, and how could that fit into your view of the future?
So to sort of paraphrase that, I think so we do have changing models of financial care, and it's episode of care, and it's kind of this capitated episode of care kind of model that we may be going to. And how does the traditional Part A type of billing for maintaining populations, if you will, or doing that, fit into all of this? And I think the answer is that I think that's a refreshing aspect to what has been recognized in the past as to what a clinical pathologist is doing, that we are directly compensated for those. Now, as we all know, there are major differences in terms of what individual hospitals and institutions will pay for all of those kinds of general sort of things that we do as clinical pathologists. And I think that is a place to look to for how to do this. And if we can incorporate that, so if we can convince people that what we're doing for utilization management is improving patient care, and if we can convince people that maybe doing more clinical pathology, at least in my prejudiced view of the world, more clinical pathology consultation on individual patients will in fact get patients out of the hospital faster, get them diagnosed faster, which I believe, and it's been hard to get data on it, and I think we haven't done that well enough at this point. And then if individual institutions are willing to pay us for it, I think it's ideal, and I think that can work. I think there's two problems with it. One is we haven't been as good as I think we need to be at trying to collect that data and look at good metrics to see how well we really are doing. And until we can do that, we're not quite sure what we're doing ourselves. We feel good about ourselves, but I don't know whether we can convince other people. And two is, in an age of decreasing reimbursement for all of healthcare, it just gets more and more challenging to get people to sort of recognize those kinds of things. But I think we can overcome both of those. I think it's a good point.
Again, thank you for a beautiful talk. I'm wondering if you can give us some suggestions or things that you might have tried to introduce clinical pathology into the clinical years of the curriculum so that medical students are exposed when it's time relevant for their clinical care in medicine and pediatrics, for example.
So what kind of things, at least we've done in New Haven, to try to get the instruction for the medical students into the clinical years? And we've done a couple things which have been good, and I think we need to do more. So we actually now have within the required internal medicine course, which is a 3-month required block for all the medical students in essentially the 3rd or 4th year. We actually have a mandatory day each month that they have to come to the laboratories, and we do a case-based laboratory medicine, CP set of exercises with them. So we do, we'll do again. We sometimes revert to standardized cases. What we like to do is to pick somebody who's on the wards right now and go through that, preferably somebody they know. That doesn't always work because we haven't gotten it smoothly worked out yet, but that's ideal. And then we kind of go through all the issues, and we try to go through the issues of, well, what does it really mean for a reference range on this? And is that really meaningful or not meaningful? And how could we have gone and gotten the diagnosis 3 days earlier if we had done different testing, and why did we bother to do this kind of testing? So that the medical students have loved, and we've gotten fantastic reviews of that. I know on the surgical pathology side, I know one group, not ours, one medical school where they've done that in the surgery rotation actually, and they brought them down on surgical pathology. The other thing we've done is we have our laboratory medicine elective, which is mostly taken by people who will not go into laboratory medicine, is based on, we try to base that on the same model used in internal medicine and surgery, which is you are attached to a resident who's doing consults, in essence, and to an attending who's doing those kinds of things. So rather than just kind of a lecture about the labs and all of that, we again do it on an individual patient care basis. Both of those things are beloved and are working. I don't know they're enough, but at least they're what we've tried to do so far. Terrific. Well, thank you very much. Appreciate it.